meeting. Renal pathology is one of the most challenging aspects in pathology. And world over, the common thread is that there are very few renal pathologists who dedicate their time and effort in studying the kidney diseases. And even if we look in our South Asian region, it's only India where we have the luxury of having stalwarts like Dr. Vinita and all my other renal pathology colleagues. So this is a very challenging but a very good upcoming field. We have, we over the years now have vast new information, new knowledge. Various stains are now available. The lesions which were completely, say, till a decade old were described just on a morphology. Now the whole description pattern has changed. We tend to go with the etiological and pathological interpretation and the classification rather than just the structural or morphological classification, which was a norm till a decade back. So it's a fast evolving field, quite a challenging one. But believe me, it would be a very rewarding one if somebody takes it up seriously. Because I was surprised that people have been transmitting renal slide images across half the globe just to get them interpreted by a reliable renal pathologist. So it's a field which is ever expanding and which is ever evolving. So let's hope we have a good renal pathologist in future from one of the students who are now listening. Dr. Vinita, please.
Yeah, thank you, Dr. Sandeep, for those words. So now we'll start with the session on pathology. So I'll be talking basically about glomerular lesions. So the plan is that I have already shared with you the cases, which are quite characteristic to let you know how do you approach a renal biopsy. So I will start with how do we process and approach a renal biopsy, and then we'll go to the cases. And when we describe the cases, we'll talk of the common lesions and how do we report it. So let's start. I hope my screen is visible to all. Yeah. So when we look at renal biopsy interpretation, it is sometimes really challenging as compared to the other medical diseases or the other pathology as a pathologist that we see the biopsies. One, because we have to recognize and integrate the injury patterns which are involving the various compartments of the kidney. Second is there may be multifactorial etiologies which will be present. So you may have multiple things going on in the kidney and you need to recognize each of them and report each of them. The other thing is that only a light microscopy does not, you're not able to make a diagnosis just on light microscopy. You need to integrate and have a multidisciplinary approach in which you integrate the immunofluorescence findings, the light microscopy, and then if you have the luxury of EM, to look at EM and then make a perfect diagnosis. Apart from that, now with more and more immunohistochemical markers coming in, you have the mass spectrometry, which is there for protein analysis, and of course, the genetic analysis. And of course, the list is growing with multispectral AIF and artificial intelligence and so on and so forth. But primarily, you need to have light microscopy and at least the immunofluorescence to make a proper renal diagnosis on a renal biopsy. So that is why it is sometimes challenging. So how do you sample a renal biopsy? The ideal situation will be to have 3 cores, one for light microscopy, one for IF, and one for EM, but that does not happen all the time. So depending upon what is the tissue that you have in hand as a pathologist, you have to divide the tissue so that you can do all the 3 techniques. So the sampling for all the 3 techniques depends also on the question which you need to address. Or if you have a glomerular disease, it is always advisable to always have a tissue for electron microscopy. This is just to show you that when you receive a renal biopsy in your lab, you can look at it and decide whether there are glomeruli or not, and then accordingly decide which part goes into immunofluorescence for light microscopy, in formalin, and for EM. So this is just to show you the microscope that we have, inverted microscope, to look at a biopsy. However, if you do not have this inverted microscope, the normal microscope with the condenser down also gives you a really good image to look at glomeruli. or you can also use a powerful hand lens to look at these. If you know if there is a cortex by seeing the biopsy that there is cortex, you can put in one core light microscopy, one core for IF and the ends into EM. If you're doubtful that there is cortex or not, because cortex has the glomeruli and you're looking for glomerular diseases, so you can divide the tissue into parts so that you have tissue in which for light microscopy has glomeruli, for IF also has glomeruli, and of course the EM at the ends will have glomeruli. So, and there are new techniques which are coming in which say that even a smartphone camera can be used to assess the adequacy of kidney biopsy. So this is one of the most important aspects so that you do not have inadequate tissue when you are analyzing for light microscopy. The other thing which is important in a renal biopsy is that you should have proper sections. Ideally, you should have a 2 to 3 micron section, because whenever you analyze the glomeruli, all our definitions are according to the section thickness. So if you are talking of mesangial area and the number of cells that are normal in a mesangial area, we are talking of a 3 micron section. If you have a thicker section, your diagnosis will not be proper. The other beautiful thing about renal biopsies is that it is a very colorful area. So our tray looks really colorful, where you have an HE stain, the periodic acid shift stain, the silver methenamine, and the Mason's trichome. And ideally, we do all the 4 stains in all of our renal biopsies. So a slide which has renal biopsies is really colorful as compared to the other biopsies which normally have only the HE stain apart from the liver. Apart from these 4 stains that we normally do in a renal biopsy, you can have other stains which can be done for fibrin. And of course, when you are suspecting amyloid, you need to do a Congo-red stain. But when you are doing a Congo-red stain, the thickness has to be 10 micron. Apart from these Congo-red, you have other stains like Orsine, where you're looking for elastin, pearls, Voncosa for calcium, and other stains for fibrosis. Most of the times when you're looking at fibrosis, Mason's trichome is adequate. Okay, so let us look at the glomerulus and the other compartments in the per-iodic acid shift stain. Why do we do a PA stain in all our renal biopsies is because the glomerular basement membrane is beautifully highlighted in the PA stain, and also the Bowman's space and the tubular basement membrane. So this is the tubular basement membrane, the Bowman's capsule, and the glomerular basement membrane are beautifully highlighted. When you highlight the basement membrane, it becomes easier for you to decide whether any proliferation or cellular infiltration or any deposit is within the capillary, outside the capillary, and so on. Similarly, when you look at areas of tubular atrophy, you are able to, on the PA stain, able to make out that there is tubular atrophy because the PA stain highlights the basement membrane. You can see the wrinkling of the basement membrane on a periodic acid shift stain. Similarly, if you're looking at hyalinosis, the color of the material that is deposited. So you can compare this with this glomerulus, which is showing amyloid deposit. So the amyloid deposit is almost negative or very pale PS positive, whereas something like a hyaline deposit is PS positive. So this is how you are able to discern what is the type of deposit which is there in the kidney renal biopsy that you are seeing. Similarly, when you look at the mesangial area, if it is PS positive, it is most likely the mesangial matrix which is increased, which is causing that enlargement of the glomerulus and increase in the mesangial area. As compared to this, as I said, this is amyloid and this is PS negative. So it is really important to look at a periodic acid shift stain, and it is often said that if you cannot do all the 4 stains in your renal biopsy, ideally you should do periodic acid shift stain in a renal biopsy. The other very important stain that we do is a silver methenamine stain. Why do we do the silver methenamine stain? One is because you want to look at the glomerular basement membrane. You can look at these spikes. So for example, you can see, if you can see closely, these are the spikes which you can see on the above the basement membrane. So these are very beautifully seen only on the silver methenamine. I'll come to this further when we talk of the case of membranous. Similarly, when you're looking at a glomerular basement membrane duplication, so again, you can see the double contours of the glomerular basement membrane on a silver methenamine stain. As I showed you earlier in the periodic acid shift stain, in silvermethanamine, you can make out this is a mesangium which is black in color. So a normal mesangium will be black in color. So this is a case of diabetic nephropathy where you can see that this mesangial area is increased and there is nodules. As compared to this case where amyloid is becoming, it is almost silver negative. So this was a case of, was in PS and this is in silvermethanamine. Whereas in this case, it was PS negative and this was also silver. It is not highlighted on the silvermethanamine. It is not black. So that is how this differential staining of the basement membrane, of the deposits, of the mesangial area helps you in your diagnosis. The other fourth stain that we routinely do is the Mason's trichome stain. Why do we do the Mason's trichome stain? Remember, we do it for deposits. We also do it for fibrosis and also for fibrin. So one is deposits. So if you see in this glomerulus, this is a Mason's trichome stain, where you see the deposits which are beautifully highlighted in the mesangial area. Similarly, if you're looking at if you look at this glomerulus, you can see this material which is deposited, which is fissionophilic. This is appearing hyaline in appearance, but because it is fissionophilic, these are immune deposits. Whereas if it would have been hyaline material, it would have appeared green in color. So that is how the differential staining helps you make out. This is a vessel which is showing you fibrinoid necrosis. So fibrinoid necrosis also appears fissionophilic in Mason's trichome stain. And of course, we do the Mason's trichome stain to look for fibrosis in the interstitium. So these are the three basic things that you're looking at in the Mason's trichome. One is deposits, one is fibrin, and the third is fibrosis. Okay, so this is a table which I have made just to tell you that overall architecture is good on an NHE stain. But if you want to look at basement membrane, the mesangial matrix and hyalinosis, it will appear magenta. Whereas amyloid will appear pale, and all of these things will be negative on the periodic acid shift stain. Whereas if you look at silvermethanamine stain, the basement membrane again is black. The mesangial matrix, normal mesangial matrix is black. So if you have any deposits, it will be negative for silvermethanamine. And if you look at the Mason's trichome stain, it is used for basically when you're looking at thrombi, fibrinoid necrosis, immune complexes, which will be fissionophilic and bright red, whereas a collagen will be green. So that is how, if you are able to grasp a hold of these stains that we are using for renal biopsies, interpretation of the biopsy becomes easier. And of course, when you look at a renal biopsies, always remember your clinical counterparts that will what will be asymptomatic hematuria, what are the things that you can see on a renal biopsy. Similarly, if it is a rapidly progressive nephritis, if the patient is presenting with rapidly progressive glomerulonephritis, you are more likely to see a crescentic. So your correlation with renal clinical parameters is very, very important. When we look at a renal biopsy under light microscopy, first we look at HE. We have four compartments that we need to look at. One is a glomerulus, second is a tubules, third is an interstitium, that is an area between the tubules, and the fourth is the blood vessels. So we always look at all the four compartments, report on all the four compartments, and generally this is the normal sequence that we look at a renal biopsy. We look at all the four compartments one by one. It is important to understand what are the terms that we use in renal pathology diagnosis. We use the term focal when less than, if you have suppose 10 glomeruli in a biopsy and only 4 are involved by a lesion, then it will be focal because less than 50% are involved. Whereas if out of the 10, 5 or more glomeruli are involved, we will say that it is a disease which is diffuse. So that is how we use the different terms in a renal biopsy, like focal, diffuse proliferative, focal segmental glomerulosclerosis, or global glomerulosclerosis. Segmental is a term when we use for one glomerulus. If you're describing a lesion for one glomerulus, if it is involving only part of the glomerulus, we say segmental. And if it is involving whole of the glomerulus, we say it is global. For segmental, what is the definition? What should be the percentage of glomerulus that should be involved, of the one glomerulus that is involved? It is said that anything which is less than 100% is segmental. So according to the new definitions, anything which is involving less than 100% of the glomerulus becomes segmental. So that you need to remember. Then we have different glomerular descriptors that we use. As I said, segmental for a part of the glomerulus involved. lobular, when these lobules are very attenuated. What happens is when you look at a normal glomerulus from the hilum towards the periphery, it is divided into different lobules, which are formed of capillaries and the mesangial matrix. When when the lobular accentuation is there of the architecture of the glomerulus, then you say it is a lobular accentuation. Something can be nodular. More likely when there is some deposit, external deposit, which is there in the glomerulus, it gives a nodular appearance to the glomerulus. And whether this nodular appearance is symmetrical or asymmetrical, you can decide on the lesion. Similarly, a term that we use is global glomerulosclerosis. Basically, glomerulosclerosis means the glomerulus has sclerosed and is not able to filter anymore. So generally, there is wrinkling of the glomerular basement membrane and there is collagenization of the Bowman's space, also known as the urinary space, and that is known as glomerulosclerosis. Normally, when we look at the renal biopsy, we generally say how many glomeruli are we seeing. So suppose we have 10 glomeruli, and then how many are showing you global glomerulosclerosis. Why is it important? Because you can, by the age of the patient, there is a number that can be normally big globally sclerosed. But if you find that the number of glomeruli are sclerosed are much more than you expect for age, then you know something is going on. There is a pathology which is causing this glomerulosclerosis. So generally speaking, less than 10% of the total number of glomeruli should be sclerosed, or if the age is more, you can divide it, you can decide based on this. So for example, someone is 90 years old. So 90 divided by 2 will be 45, minus 10 will be 35. So it should not be more than 35% of the total number of glomeruli. So once we know what are the terms, how do we define, then we know what are the different descriptors that we use, then we should know what are the patterns are there. So ideally, all glomerular diseases are described by patterns. So a pattern could be a normal or a minimal change type disease. It could be segmental, focal segmental glomerulosclerosis, a membranous pattern where you see the membrane is very highlighted or thick, a mesangial-proliferative type of a pattern where the capillary loops are patent, but the mesangium is increased. You have a diffuse proliferative type of a pattern where most of the glomeruli are involved by endocapillary proliferation. And what is endocapillary proliferation? Whenever there is infiltration by inflammatory cells, for example, neutrophils, along with proliferation of the mesangial cells and prominence of the endothelial cells, there is occlusion of the capillary loops, and then we use the term proliferative endocapillary hypercellularity. And if it is diffuse, we say it is diffuse proliferative glomerular disease. A related term is membranoproliferative glomerulonephritis. So apart from endocapillary hypercellularity, the glomerulus also shows you duplication or the double contours of the glomerular basement membrane that I had shown you on the silver methenamine stain. Sometimes in the Bowman's space, you have proliferation of cells. And this is a formation of a crescent because it is basically an English term. It is like a moon. You have a crescent shaped formation in the Bowman's space, and then you say it is a crescentic glomerulonephritis. We say crescentic glomerulonephritis when more than or equal to 50% of the glomeruli are involved. If less than or equal to 50% of the glomeruli are involved by crescents, we describe the basic disease, for example, MPGN with crescents or diffuse proliferative glomerulonephritis with crescents. And now if you look at this, I have shown you a case of amyloid. So if you have something which is deposited, it will cause a nodular accentuation of the glomerular lobules, and that is known as nodular glomerulosclerosis. When we look at hypercellularity, I've already talked about, this is the normal. What is mesangial hypercellularity? As I said, there is increase in the mesangial cellularity. Normally, there are less than 3 nuclei per mesangial area. So if you have more than or equal to 4 nuclei, then you say mesangial proliferative. This is endocapillary hypercellularity, where there is occlusion of the capillary loops by proliferation, as I said, of mesangial cells, endothelial cells, and infiltration by inflammatory cells. This is a cellular crescent. This is fibrocellular and fibrous. How do you define these? It is dependent on the percentage of fibrous component and the cellular component. Most of the places you will find that the definition says 75% cellularity and 75% fibrosis. So if it is 75% cellular, it is a cellular crescent. If it is more than 75% of fibrous, it is a fibrous crescent. And if it is more, it is a mixture of both, it is a fibrocellular crescent. You need to distinguish a crescent from a pseudocrescent. What is a pseudocrescent? Pseudocrescent is formed by the proliferation of the visceral epithelial cells which surround the glomerular capillary loops. So this is a parietal epithelial cell, and here is where the visceral epithelial cells sit. So the crescent is formed by the proliferation and infiltration of the parietal epithelial cells and inflammatory cells, whereas a pseudocrescent is formed by the visceral epithelial cells. Okay. The other thing in a renal biopsy is very important is the immunofluorescence. In routine, we do these immunofluorescence stains, that is immunoglobulin G, IgG, IgM, and IgA, and complement components C3 and C1q, and light chains kappa and lambda. So every renal biopsy, we do all of these stains and look at it under the immunofluorescent microscope. When we describe the immunofluorescence pattern, we can have a mesangial pattern. For example, in IgA nephropathy, you have these mesangial deposits, or you can have a peripheral granular capillary wall deposits, which can be coarse, or which can be, it can be a linear GBM deposits. They can be both granular capillary wall and mesangial deposits. And you may have band-like capillary wall deposits typically seen in Des deposit disease. You may have fine granular capillary wall deposits, which is typically seen in membranous glomulopathy. Or you can have a coarse granular to chunky deposit. So you can define the pattern of deposits as capillary wall or mesangial. If it is capillary wall, whether it is linear, whether it is coarse granular, or whether it is fine granular. So that is how you define the immunofluorescence pattern of staining in the renal biopsies. The other things which you need to know, these are the lesions which you need to identify to make a proper diagnosis. Something known as a wire loop lesions. Wire loop lesions are nothing but these are large subendothelial deposits. Because they are large, they have occupy the whole of the capillary, they appear like a wire loop. And that is why we say that these are wire loop deposits, typically seen in lupus nephritis. Similarly, these are, as I showed you in the earlier, this is the same picture where you can look at these hyaline thrombi. These are not true thrombi, but these are pseudothrombi formed by immune deposits. Why I'm saying these are immune deposits? Because they are fissionophilic on the empty stain, right? So this is, these, and they are very hyaline appearing. So these are hyaline immune deposits, typically again seen in lupus nephritis. Then on empty, as I said, you can look at fibrinoid necrosis. What is fibrinoid necrosis? When it is involving the glomerulus, there is disruption of the capillary wall with formation of these fissionophilic deposits, which can be very, very subtle on the glomerulus. And when they involve the vessels, it will cause this fissionophilic deposit with destruction of the vessel wall. So this is fibrinoid necrosis. And of course, tubular atrophy. We have three types of tubular atrophy. Typical tubular atrophy, which is known as a classical type of tubular atrophy, shows you a thickened, wrinkled, and lamellated tubular basement membrane. You may have a thyroidization of type of a tubular atrophy, typically seen in chronic pyelonephritis and chronic diseases. And sometimes you may have an endocrine type of tubular atrophy, which I will show you in a high power. This is a typical type of a endocrine type of tubular atrophy, where you have a narrow lumen, but the cells are not very damaged. They are, and you have reduced diameter of the tubule and simplified epithelium. You compare it with the previous classical type of tubular atrophy, where you can see the typical flattening of the tubular epithelial cells. Whereas in this endocrine type of tubular atrophy, there is reduction in the diameter, and usually they appear in clusters, and it is typically seen in chronic ischemia. As I said earlier, we use Mason's trichome stain to look at interstitial fibrosis. It is important when there is expansion of the interstitium to look at interstitial fibrosis, because it is a very important prognostic factor. Of course, the vascular lesions are the hyalinosis, as I showed you earlier, and hyalinosis will appear green in silver methylamine and will not be black. Okay. So these lesions will again be taken up by Dr. Alok when he'll be talking about tubulointerstitial and vascular lesions. This is something which is known as an arteriolosclerosis and arteriolosclerosis, depending on the vessel which is involved. And of course, you can use the different stains to look at them. This is something about thrombotic microangiopathy, again, which will be covered up by Dr. Alok Sharma. And it is, again, we have to look at Mason's trichome stain to look for thrombotic microangiopathy. These are the different conditions which can produce TMA. And of course, sometimes rarely you may also have vasculitis in the biopsies. And these are the typical patterns of vascular injury. So I have basically tried to tell you the overview of the renal biopsy interpretation, covering all the 4 compartments of the kidney. Today, I will be basically talking about the glomerular lesions, and tubulointerstitial and vascular lesions will be covered by Dr. Alok in the next class. So this is the history that I gave you. This was a 12-year-old male child with nephrotic syndrome.
Hello.
And steroid dependent.
Hello, ma'am.
Yes.
I'm sorry to interrupt you. I just have one question. Can you just tell the residents, is there any adequacy criteria to report the kidney biopsy?
Right. Absolutely. So generally, when we look at a renal biopsy, we talk about 7 glomeruli. So ideally, you should have at least 7 glomeruli in a renal biopsy to say that it is, I'm talking basically about native renal biopsies today. So you should have at least 7 glomeruli in a native renal biopsy to say it is adequate. Having said that, it doesn't mean that if you have a biopsy which does not have 7 glomeruli, you just say it is inadequate. Try to look at whatever glomeruli that are seen. Sometimes you can make a diagnosis even with 1 glomerulus. For example, you have a renal biopsy in which you see 1 glomerulus showing you amyloidosis. You can, of course, make a diagnosis. Or, for example, membranous nephropathy, you can make a diagnosis. It will be difficult to make a diagnosis of FSGS or other lesions if you just have 1 or 2 glomeruli. So this is basically relative, but yes, that is the adequacy criteria for renal native biopsies. Thank you, Sheetal, for pointing that out.
Yeah, thank you, ma'am.
Yeah, so now we come to the case history 1. That was a 12-year-old male child with nephrotic syndrome, steroid dependent. So you have a young child with nephrotic syndrome. The first thing which comes to your mind is, so Ruby, can you just take up this case? Can you hear me? Ruby? Ruby, please open your mic and your video and please take up this case. We have, I think Mumpy is there. Mumpy, can you take up the first case?
Yes, ma'am.
Yeah. So this was a 12-year-old male child with nephrotic syndrome. What is, before looking at the renal biopsy, what do you think should it be? The first thing which comes to your mind in a 12-year child with nephrotic syndrome.
Minimal change disease can be.
Okay, good. But it is also written that it is a steroid dependent. So what do you expect now? Generally, nephrotic syndrome, minimal change disease, if it is steroid responsive, they will not do a biopsy. So it is steroid dependent. So what else should you keep in mind? Apart from the other pathologies, of course, but what does come to your mind apart from minimal change disease?
Streptococcus.
Focal segmental glomerulosclerosis, ma'am.
Okay, good. Who is saying that?
I'm Ashwati.
Okay, good. Okay, so this is your, before looking at the biopsy, these are the 2 things that you're thinking. Of course, you look at the biopsy as a whole. Okay.
Ma'am,
So
IgA
now
nephropathy can be considered, ma'am. IgA nephropathy.
Okay, because it is a 12-year-old child. Okay, agreed. But I have not given you further the urine findings or any other history, of course. Okay, let us now look at the biopsy. So, Mumpy, would you like to describe the biopsy?
Yes. Okay.
Tell me what is this? What is this stain? First of all, what is this stain on the left-hand side?
On the left-hand side, this is H1 stain. On the right-hand side, this is PA stain.
Very good. Very good. So what do you see on the light microscopy on a normal HE stain? What do you think is seen in this biopsy? So you see this is the glomerulus and these are the tubules. Okay. So what is your finding?
Now I can see 2 glomeruli.
Both are showing mesangial hypercellularity.
What is the definition of mesangial hypercellularity? I told you.
More than three, that is
More than 3 cells. Oh, so let us look at the mesangium in the PAST. So now this is basically, this is the area of the mesangium which is surrounded by loops. So this is the mesangium, right? You can see my pointer. So this is a mesangium and you can see maximum 1 or maybe 2, but this is also the endothelium. So I have only 1 cell or maybe no cell here. Okay, now let us look at the mesangium here. Okay, you agree that this is a mesangium?
Yes.
Okay, so if you look at this area, this is the endothelial cell and you have only 2 cells. Maximum is 2 cells, right? So you have to differentiate by the location of the cell, whether it is a mesangial cell or whether it is an endothelial cell.
Okay.
So you do not have more than 3 cells in any of the mesangial area that you are seeing. Okay, so there is no mesangial proliferation. What else? Do you, so first thing is, do you think the capillary loops are patent?
Yes.
There is no mesangial cellularity. There is, the loops are patent. Do you see any crescent in the Bowman space?
No.
No. Okay, so what do you think?
Yeah.
Basement membrane is doesn't appear thickened either.
Yeah, right. So on light microscopy, do you think this is, someone is saying the GBM appears thickened. We will look at the other case, maybe because it is PS, but try to compare it with the Bowman's capsule also. So someone's saying it is a normal glomerulus. Good. So it is looking like a normal glomerulus. Even when you look at a normal glomerulus on a renal biopsy and light microscopy, kindly try to assess the size of the glomerulus. So in conditions like FSGS, like focal segmental glomerulosclerosis, there is some amount of glomerulomegaly. So if the glomerulus is occupying more than 50% of the area of a high power field, that is a 40x, you start thinking that there is glomerulomegaly. So if you see a biopsy with normal appearing glomeruli, but if you think there is glomerulomegaly, always try to search for FSGS, do more serial sections. So that is a tip that you always need to remember when you look at renal biopsy. Okay, so at this point, it looks like a normal glomerulus. Okay, so this is the glomerulus in all the 4 stains. So this is, Mampi, what is, this was HE, this was PS, what is this? Lower left corner.
This is silver.
And this is silver. So all in all, the 4 stains of glomeruli absolutely look normal. But in some area, I found this. Even in this, you can make out. You see this? What is happening to the tubules? I showed, that is why I showed you tubules in my previous slide. So you need to make out what is this?
Hyalinization is there.
Atrophy.
When do you say hyalinization?
When it is silver negative. There is
hyaline is when you find some material deposited. Do you think there is some material which is there in the tubules?
Ma'am, liquid accumulation. Liquid
Tubular
accumulation, ma'am.
Can you repeat it?
Liquid accumulation, ma'am.
Where do you think is a liquid accumulation?
Ma'am, in the tubules.
No, there is completely, they are empty. You look at the tubules. Where is the liquid?
Tubular atrophy.
See, what I had shown you in atrophy, I had shown you 3 types of atrophy. I had shown you what are the 3 types of atrophy. Classical,
Thyroid,
thyroidization, and endocrine type. So this is a classical type of a tubular atrophy. There is no liquid anywhere. It is completely empty. Here also there are tubular epithelial. This is early atrophy, where you can see that the tubular epithelial cells are still there, but there is wrinkling of the tubular basement membrane. So there is tubular atrophy. So when you look at glomeruli, which are looking normal, but you're finding tubular atrophy, or you're finding glomerulomegaly, the glomerulus is enlarged, what should you think? What should you think? always rule out?
Any immunological cause?
No. No, I told you in the biopsy, this was a patient who was you're thinking of MCD with steroid dependent state. So you have to always rule out focal segmental glomerulosclerosis. Okay. So because FSGS can also show you normal looking glomeruli, right? But there are only segmental lesions. So whenever you find, you're not finding a segmental lesion in the glomerulus, but you're finding tubular atrophy, always try to look for FSGS. So this was immunofluorescence negative, and so that was a diagnosis. So any other evaluation as a pathologist? So I showed you normal appearing glomeruli with tubular atrophy. What will you do next?
Electron microscopy.
What will you look at electron microscopy? What do you want to see?
Diffuse podocyte proliferation.
Podocytopathy. Okay, you want to look at podocytopathy. So what do you expect if you are thinking of minimal change disease?
There will be diffuse podocytopathy.
So even if you are looking at minimal change disease, or if you are looking at focal segmental glomerulosclerosis, both will show you podocytopathy, right?
Yes.
Podocyte effacement will be seen. So podocyte, so looking at electron microscopy will not help you differentiate between minimal change disease and focal segmental glomerulosclerosis. What will you do as a pathologist? You may not have an electron microscope, and even electron microscopy will not help you. What will you do as a pathologist?
Genetic studies can also be done now.
Genetic studies can be done, but something which is more simpler, which is in your hands, which you can do.
IHC.
What for IHC for what?
CD80 podocyte.
No, we don't do it routinely. Those are only research things that are done. In a routine renal biopsy, you never do CD80 staining. It will never help you. Think of something more simpler. So if it would have been just this biopsy where you have normal glomeruli, I would have given it as a minimal change disease because a child was presenting with nephrotic syndrome. If it was not for nephrotic syndrome, I will say it is unremarkable glomeruli. But when I start seeing tubular atrophy, I will do a serial section and look for FSGS. Okay? So that is all you need to do. That is, you need to do serial sections and try to look for focal segmental glomerulosclerosis. Now, what is focal segmental glomerulosclerosis? So we'll talk about it in the next slide. So if you see a normal or a minimal change pattern on light microscopy, if IF is completely negative, these are the conditions. If IF is positive, there are immune deposition diseases which can show normal appearing glomeruli, something like an early membranous nephropathy, IgA class 1, the Haas class, or lupus nephritis class 1, or diabetic class 1. So all of these can show you a normal or an MCD pattern, but immunofluorescence therefore becomes very, very important to make these diagnoses in an early stage. Whereas if IF is completely negative, you think of MCD, because the nephrologist has done a biopsy, always keep in mind that you have to rule out an unsampled FSGS. Of course, Alport's and thin basement membrane and lupus podocytopathy are the conditions which you can also show you a normal or an MCD pattern. So what is FSGS? As I told you, something which is focal, that is involving less than 50% of the glomeruli, and segmental, that is involving part of the glomerulus. So this is a focal segmental glomerulosclerosis because less than 50% of the glomeruli were involved. And this is segmental lesion where you can see that the capillary loop basement membrane is adhered to the Bowman's capsule. Every one of you can see that. This is a normal and this is adherence, and you can also see a foam cell here. So this is focal segmental glomerulosclerosis in this biopsy because we did serial sections and tried to look for it. If we will not have done serial sections, we will have missed focal segmental glomerulosclerosis in this. When we look at focal segmental glomerulosclerosis, we need to look at the different patterns of FSGS. So whether it is, I'm not going into the detail of all of these, but if you are able to identify FSGS, I think that is adequate. Okay. So The FSGS pattern, as I showed you the MCD pattern, FSGS pattern on light microscopy may be primary or it may be seen in a lot of diseases like Alport syndrome, IgA nephropathy, drug-induced hypertension, obesity. So you need to consider the immunofluorescence finding in making a diagnosis. And of course, a family history, the urine analysis, and everything has to be taken into account to think of a possible diagnosis. So you talk about podocytopathy. So what is podocytopathy? There is complete podocyte foot process effacement. So the podocytes become completely flattened, and this is what is known as podocytopathy. There is condensation of the cytoskeletal segment filaments at the base. Whereas in Alport syndrome, you have this. What is this known as? Anybody? What is this Alport syndrome? What happens to the basement membrane? What are we seeing? Bumpy, what do you think this is? This is the normal basement membrane, glomerular basement membrane, and this is the basement membrane in Alport syndrome. This is becoming very irregular. You can see the irregular wavy appearance, and you can see that this is the lamina densa, normal lamina densa, which is quite even, whereas in this you can see the splitting of the lamina densa, right? You can make out. So this is known as lamellation and splitting of the lamina densa, which is typically seen in Alport syndrome. Okay. Okay, so now summarizing what we were looking at in the MCT FSGS pattern when we integrate light microscopy, immunofluorescence, and EM. These are the conditions which show you podocytopathy. These are the conditions which show you GBM alterations. And these are the conditions which have a normal MCT or an FSGS pattern, but they will show you immunofluorescence positivity. There are certain conditions for which you can make a diagnosis just on LM and IF, like MCD, FSGS, or all of these conditions with immunofluorescence deposits. But there are certain conditions which require electron microscopy for making a diagnosis, like thin basement membrane disease, lupus podocytopathy, Alport syndrome, and nail petalus. So if you have an MCD FSGS pattern, always look at your immunofluorescence. If the immunofluorescence is negative, you can definitely make a diagnosis of minimal change disease, provided the patient is having nephrotic syndrome and of course FSGS, and then decide what is the type of FSGS that you are seeing. So before coming on to the case history 2, I will request Dr. Sandeep Mahajan to please give his expert comments and let us know if you want to add as anything as a nephrologist.
Well, Dr. Vinita has very beautifully shown the importance of critically analyzing a biopsy before arriving at a diagnosis. So, a few telltale signs would always be there. So, it was a steroid-dependent nephrotic syndrome, not a steroid-resistant nephrotic syndrome. That would mean that genetics are unlikely. It's most likely a FSGS. That's why at a 12-year-old we would have done a biopsy. Normally, for a child, the percentages of having a MCD is so high that you don't do a biopsy and give a trial of steroid straight away. So it's only steroid resistant or a steroid dependent who would undergo a biopsy. And for a steroid dependent, the invariably diagnosis would be FSGS. Though now we broadly clump them as podocytopathy. But important to realize is that the moment you have a diagnosis of FSGS, then the whole connotation clinically changes, because then these are the patients who are more resistant to treat, who are more have higher chances of relapses and subsequent progression to chronic kidney disease. MCD, if in sustained remission, would not progress to chronic kidney disease. And also, as ma'am highlighted, FSGS has more tubular involvement. So you can have, if you do a urine routine, if you have glycosuria in a patient who has a normal sugar levels, again, that might give you a suspicion that this might be an FSGS or something like an amyloid, which would have both glomerular as well as tubular involvement. So clinically, you would tend to correlate so many things, and still it's the diagnosis which would be established only on a renal biopsy. and also analyzing all the three components, as she has very beautifully pointed out, that the same morphology, even a normal looking morphology, can be harboring so many diagnoses. So to actually come to that, you would have to do all the three staining patterns to arrive at a correct diagnosis. And that would decide upon the further management.
Thank you, Dr. Sandeep. That was really nice. I think it is very important for the students to understand that it is how do you, when the history comes to you, how do you start interpreting in your mind that what are the possibilities? And that is how I always say that slide is our patient. So a slide, when you have your clinical, for me, a slide is my patient. So that is how I look at it and try to decide what can be the possible diagnosis. Thank you. That was a very important point that you raised. So now let us go to the second case.
One
I
question,
will
ma'am,
now, yeah.
before that. So somebody has asked, Simon has asked that lupus podopathy have IF findings.
Lupus podocytopathy will not have the typical full house pattern that you see in lupus nephritis. That is how it is so important that in a patient of lupus, that is systemic lupus erythematosus, if you have a biopsy which is showing you a normal appearing glomeruli and the IF is negative, always remember the immunofluorescence will be negative and you have normal looking glomeruli, you will start scratching your head. What do you want to say? Do you want to say that it is a normal biopsy? This patient does not have lupus nephritis. But always remember at the back of your mind that there is a term which is known as lupus podocytopathy, and that patient may be presenting with proteinuria because of the podocytopathy. Immunofluorescence will show you very minimal or almost negative deposits. So that is why if you look at my presentation here, I said podocytopathy and kept lupus podocytopathy in the box above, not in the box with immunofluorescence or electron dense deposit. Because EM will not be available to all. IF will be available to all of you. So IF will show you no deposits. In a patient who has systemic lupus erythematosus, the clinician is thinking of lupus nephritis. However, he or she is in a doubt. You do a biopsy, you don't find any deposits, but there is proteinuria. Always think of lupus podocytopathy. I hope I have answered your question.
Thank you, ma'am.
Okay. So now let us go to case number 2. And I'll request now Sarika to take up this case.
Okay, ma'am.
Okay, now we'll be a little faster. We have seen the first case so that we compete on time. Okay. Yes, Sarika. Sarika, can
Yes,
you hear
ma'am.
me? Yeah. Please read up the history and let
Yes,
me know
ma'am.
what is your... Yeah, read up the history and let me know what
35
are your expectations.
35-year male presented with pedal edema, which is of nephrotic syndrome. Most probably
Yeah.
adult male with nephrotic syndrome, membranous nephropathy.
Very good. That is the first thing which comes to your mind. Okay, let us look at the biopsy.
Okay.
What do you think? What are the findings?
Okay.
Well, first tell me the stain on both sides, left and right, and then you go on to the findings.
Left one is H&E stain, ma'am.
Good. And the right?
And right one is PAS.
Very good. What is your finding?
Left H&E stain showing thickening of capillaries, capillary walls, and no endocapillary proliferation, no crescents.
Good.
And PAS also shows diffuse capillary wall thickening.
Okay. So let me just correct you. We will not use the word diffuse because if you don't know whether all the glomeruli are involved or not. On seeing on one glomerulus, I can only say it is global, right?
Okay.
But yes,
Okay,
if all the glomeruli are showing the similar picture, I will say it is diffuse and global thickening of the glomerular capillary loops. Okay, go on.
Okay, ma'am.
Yeah. Any other thing that you see in phonetic acid shift?
Mild interstitial edema.
Okay, very good.
And mild inflammatory infiltrates in the interstitium.
Very good.
And tubular atrophy.
Very good. So you can see the early tubular atrophy. Why I'm saying early tubular atrophy? Because the tubular epithelial cells are still cuboidal, right? But the
Yes,
wrinkling
ma'am.
of the tubular basement membrane has started. Apart from the thickening of the
Yes,
glomerular basement membrane that is beautifully seen in this glomerulus, you also see some mesangial matrix expansion. You agree?
okay, ma'am. Okay. Yes, ma'am.
Yeah. So as I said earlier,
Yes.
you say mesangial proliferation only when the number of cells are more than
3.
3.
3.
So if you see this mesangial area, you just see mesangial matrix expansion. The number of cells are only, here it is 1 only, right? So this is how
Okay,
you
ma'am.
decide whether it is mesangial proliferation or not. Okay, let me go to the next picture. So what do you see in this? What is this stain? What is the
Silver
stain?
methanamine stain, ma'am.
Very good.
Uh,
So what do you see?
some spikes and
Okay.
membranous spikes.
Okay. So you see some membrane thickening and spikes. How do you describe
Yes.
these spikes? These are typically known as epimembranous.
Domes.
No, they are not
Domes.
domes. They are epimembranous ergyrophilic spikes. Okay, that is a term that
Okay.
we typically use. Okay, let me show you these in the high part. So in the high part, if you look at them in the high part, I just put my battery. Okay, so in the high part, if you see these spikes, typically beautifully seen.
Yes, ma'am.
Hello, ma'am. I think there's some internet interruption from ma'am's side.
Yeah, I think she's logged out. Yeah, she will connect in a while. Yeah.
Can you see?
It's loading, ma'am. Yes, ma'am.
Yes, ma'am.
Sorry, there was my laptop just had no battery. Okay, I hope now you can see it. So this is in the high where you can look at the spikes, right? Students, can you look at
Yes,
it?
ma'am.
Can you see the spikes?
Yes.
Now this is a beautiful empty stain. Does not happen always. If you have a good empty stain, you can look at the deposit. So why do spikes form? This I have taken just to show you why do spikes form. So the spikes are basically the reaction of the basement membrane. So the spikes which you see are the black is the GBM material that you see. The area in between the spikes are the deposits, which can sometimes be very nicely seen on an empty stain. A typical empty stain, a very nicely done empty stain will show you these small fusionophilic deposits. Can you see these deposits along the glomerular basement membrane? So these are the deposits, and the basement membrane reaction between the deposits appears like spikes on the silver methenamine stain. So what do you find on immunofluorescence? Typically you have IgG staining, that is immunoglobulin G staining, which shows you granular staining along the capillary wall. How do you make out whether it is granular or linear? Look at the periphery of the glomerulus, in the peripheral capillary loops. You can make out that this is a granular staining and this is not a linear staining that you typically see in anti-GBM disease. So in this patient, there was an IgG staining. Apart from that, there was C3, kappa, and lambda. All the other three stains at IgG, IgA, and C1q were negative. Okay. So this will be, what was your diagnosis, Sarika?
Membranous nephropathy.
Okay, so this is just to summarize all of that we have seen. So this is membranous nephropathy. So we have a membranous nephropathy. This is an easy diagnosis for all of you, isn't it? So what do you, this is my question to you. Any other evaluation as a pathologist that you would like to do?
Screen for autoantibodies.
Right. What autoantibody? You have a renal biopsy with you. What will you do? You will tell the nephrologist to do for autoantibodies. What are autoantibodies?
Plaque-2R.
Clear. So you will ask the nephrologist to do a PLA2R in the serum.
Yes, ma'am.
But as a pathologist, what will you do? That is for the nephrologist to send the sample when you give him the report of membranous nephropathy. But as a pathologist, what else will you do? This was a very clear-cut case of membranous. Anybody else can answer? Hepatitis B.
Electron microscopy.
Electron microscopy, why? You want to, if you want to confirm your diagnosis, yes. If you're finding any other odd feature that you're thinking of something which is a secondary cause of membranous, then yes. All cases of membranous nephropathy, electron microscopy will not help. Like I showed you in the first case, don't think that electron microscopy is the only solution for all your diagnosis. Electron microscopy may or may not help in all your cases. Like for MCD versus FSGS, electron microscopy will not help you. You need to do further serial sections and look for FSGS. Similarly for this, yes, Rashi is saying, no, Rashi is telling you something for membranous. What will you do?
IHC can be done, ma'am. PLA2R.
Yes. Very good, very good. So, as a pathologist, you have a tissue, you will do the immunohistochemistry or immunofluorescence, whatever you want to do. For the first thing is you will do it for PLA2R. So, let me talk about membranous nephropathy further. So, initially, about 20 years back, we were just saying it is primary versus secondary membranous. For example, lupus has secondary membranous nephropathy. But now we have a lot of antigens which we now to look at. So there is a major leap in looking at membranous nephropathy. And this was something in 2009 when we had the first PLA2R antibody which was discovered. So now we look at it in all our biopsies which have membranous-like pattern. And now apart from PLA2R, there are a large number of other antigens which have to be looked up in the renal biopsy, which can be stained on the renal biopsy for looking at what is the cause of that membranous nephropathy. What is the pathogenesis basically which is causing this membranous pattern to appear? So the one of the most common, as I've showed you in this picture, is PLA2R, which almost forms 50 to 60 to 70% in our group. But there are a large number of other antigens which you can also look at on the renal biopsy, which we don't do all of them, but we do some of them depending on the history, like NEL1, thrombospondin, like semaphorin in children. So these are some of the antigens which we as a pathologist need to look at, especially PLA2R. And this is how immunohistochemistry for all of these looks at. So if you look at a PLA2R, it will appear like a granular staining along the glomerular basement membrane. This is in the high par where you see the PLA2R staining along the glomerular basement. Similarly, exhaustocin typically seen in lupus nephritis, semaphorin B, and so on and so forth. So PLA2R can be done by both by IHC and by immunofluorescence. Okay. So as I told you, there are a large number of antigens which we can do. PLA2R, NEL1, exhaustocins, thrombospondin, and so on. So for children, most of them will again be PLA2R positive, but many of them will be also semaphorin positive, which is more often in children as compared to adults. But in children, many of those remain undiagnosed or unclassified. Whereas in adults, most of them are PLA2R, sometimes NEL1, typically seen with those face creams, that is the brightening and the whitening face creams. And And of course, you can, according to the associated diseases, you can think about the different antigens which you need to stain. So this is just first you do PLA2R. If it is negative, then we do NEL1, and then we do all the other stains. So as a pathologist, now remember that membranous nephropathy can be PLA2R positive or can be positive for other antigens. So now let me talk about membranous pattern of injury. So one I talked about is membranous nephropathy, which can be primary, secondary. Secondary, when I say that, suppose secondary to any other pathogenesis, for example, lupus nephritis, hepatitis B can also, hepatitis B virus can also cause, when it causes renal disease, can HBV positivity can cause membranous, and it will be secondary membranous. But there are other conditions in which you can have thickening of the GBM. That will also be a membranous pattern. That you will not say membranous nephropathy, but you will say membranous pattern of injury. It has a positive IF like diabetic nephropathy, monoclonal immunoglobulin deposition disease, amyloids, dense deposit disease, and all others. And there are conditions in which you can have thickening of the membrane, that is a GBM, like Alports and collagenofibrotic. So now you note that Alports can present like an NCD pattern, it can have an FSGS pattern, and it can also have a membranous pattern. So that is why, as I said, started the talk by saying that you have to identify the patterns, and then only you can reach to a diagnosis. Okay. Dr. Sandeep, would you like to add on the case number 2 where we talked of membranous nephropathy?
Yeah, I believe there was a question in the chat box which said that does it make any difference? Well, getting to a diagnosis of primary and secondary can make a huge difference. In fact, if the patient has normal renal function, we are thinking it's membranous, and serum PLA2R comes positive, then we might not even do a biopsy. So it would be those patients in whom we are not suspecting to be a primary membranous, then only we would do a biopsy, and if the renal functions are impaired. So it does make a difference whether the patient has serum PLA2R positivity or negativity. Same with the tissue. The other thing, Dr. Vinita, I would like to have from you is the differential staining of the IgG pattern. So you can have different subclasses of IgG which can still give you some lead, whether you are dealing with a primary or a secondary MGN. So even that can be a good lead. Then there can be a pattern where you have MGN predominantly with FSGS pattern. So that would be those cases which would be more difficult. Normally in membranous, we would tend to wait, give antiproteinuric therapy, not start off with immunosuppressant straight away. But if the patient has FSGS, then these are the patients who are unlikely to respond simultaneously, and you might actually tend to give immunosuppression earlier. So from pathologists, we would be expecting all these reports, and then at times that can help us in a great deal in deciding which way we need to treat this patient.
Yes, yes, I completely agree, Dr. Sandeep. I did not talk of IgG 1, 2, 3, and 4, all of these subclasses of IgG because these are postgraduates in pathology. They may get confused. But yes, you are absolutely right. Now we have started staining for all of these subclasses of IgG. So we need to do IgG 1, 2, 3, and 4, and then it helps you, the differential staining in all of these subclasses helps you definitely to make a diagnosis. And as you said, apart from the classical case that I have shown you of membranous, when you have FSGS and other lesions, or you may have some mesangial cellularity, always think of other conditions, and accordingly the nephrologist will be able to treat the patient. Thank you so much for those comments. So now can we move on to the third case? And can I ask Dr. Aswasti to please take up this case?
Yes, ma'am. The 30-year-old female presented with hematuria and skin rash. On investigation, urine protein 3+ with 24-hour proteinuria 2 gram, and creatinine level is 2.1 milligram per deciliter.
So how do you interpret this clinical history?
Ma'am, an adult with proteinuria with creatinine more than normal level, which is predominant of a chronic kidney disease with a both picture of nephritic and nephrotic, ma'am.
Do you think it is nephrotic? What is generally what is The cutoff that we use for nephrotic syndrome.
Ma'am, proteinuria should be more than 3, ma'am.
But this patient has?
Moderate only, ma'am, yes.
So it is subnephrotic proteinuria. So this is a patient who has hematuria, skin rash, subnephrotic proteinuria, and renal failure, right?
Yes,
While
ma'am.
renal. Yeah. Okay. Now let us look at the biopsy.
Yes, ma'am.
Okay. So what do you think is a stain, and what are we looking at in the renal biopsy? So tell me about all the compartments that you are seeing in this biopsy field.
The glomerular
How many glomeruli? Stain.
HNE, ma'am.
This is not an H. Do you look at the basement membrane?
Sorry, ma'am. It's a past stain, ma'am.
Okay, good.
Past stain showing the, we can see the glomerulus with the mesangial hypercellularity, ma'am.
Very good. Very good. So this is the mesangial area. Now,
Yes.
the people who were saying in the MCT that there is mesangial hypercellularity, now you can look at the mesangial hypercellularity. So this is a mesangium which is increased. There is an expansion of the mesangium and increased cellularity. Look at these blue looking nuclei. Okay. So there is definitely mesangial hypercellularity. What else?
With the increased mesangial matrix.
Yeah. So there is increase in mesangial cellularity and matrix. So the mesangial expansion is being caused by both of these conditions. Both of these. Anything else that you see?
Ma'am, endocapillary proliferation can we say, ma'am? Endocapillary.
Very good. Very good. Very good. So you can see endocapillary hypercellularity. Why we are saying, and so this area is showing you only mesangial cellularity.
Yes,
whereas
ma'am.
this area is showing you endocapillary hypercellularity because there is obliteration of the capillary loops also. Right?
Yes, ma'am.
So this is endocapillary hypercellularity. So there are areas of mesangial hypercellularity with segmental endocapillary hypercellularity. What is this?
Sclerosis.
Yes. So do you see this?
Segmental.
Segmental sclerosis. So I had shown you what is segmental sclerosis when there is attachment of the capillary of the GBM of the capillary loop GBM with the Bowman's capsule, right? So this
Yes,
is segmental sclerosis. So there is some amount of endocapillary hypercellularity along with segmental sclerosis, and these glomeruli are enlarged. So
Yes,
you see mesangial hypercellularity, segmental endocapillary hypercellularity with subsegmental sclerosis. Okay. What is seen in the tubules?
And atrophy.
Very good. So this is tubular atrophy.
And interstitial
So you
formation, ma'am.
very good. Apart from that, you also have acute tubular injury. I'm not talking about tubular injury and other things because I thought that will be covered up in the next class. Okay. So what do you think will this be? With the history that you have, what comes to your mind as a diagnosis?
IgA nephropathy.
Very good. I had given you, so this is in a high power to show you this typical synecdoche which is being formed, the increase in the mesangial area with some patent loop with the periphery and endocapillary hypercellularity. And this is the tubular atrophy. Okay. So this is a typical, this is the same renal biopsy. What is this seen here? In this, you had just synecdoche formation. But in this, now you start seeing a typical, what is this?
Segmental sclerosis.
Very good. Very good. So there is segmental sclerosis. So there is a glomerulus which is showing you segmental sclerosis. And in this, there is no endocapillary hypercellularity. What you are seeing is some mild mesangial increase and the loops are all patent. Right?
Yes, ma'am.
So in the same biopsy, you are seeing mesangial hypercellularity. You are seeing segmental endocapillary hypercellularity. You're also seeing segmental sclerosis and you're seeing tubular atrophy. So these are your findings.
Yes,
this is the immunofluorescence that I gave you. How will you describe this immunofluorescence?
IgA deposition in the mesangium, ma'am.
Yeah.
Pattern.
Very good.
Pattern.
Yeah. So there are mesangial pattern of staining of the IgA. You do not see capillary wall deposits, right? So
yes,
this is IgA and it was C3, kappa and lambda positive, whereas all the other was negative. So now this is what is your diagnosis, as you said, is?
IgA nephropathy, ma'am.
IgA. Now again, my question is, how will you report this renal biopsy?
Ma'am,
How will you report? You will just say it is an IgA nephropathy, or you will like to add anything else?
ma'am, we should mention in renal biopsy about the cores, ma'am. How many cores?
Yes, yes. That will you will tell in all renal biopsies how many cores are there, how many glomeruli are there, right?
Yes, ma'am.
What is in the gross? You will always mention what is the length of the cores that you receive. That is all fine. But now you made a diagnosis of IgA nephropathy. Will your bottom line just say IgA nephropathy as a conclusion in your report, or will you like to add anything to the report? You've already done your immunofluorescence. You've already looked at the biopsy. So what else will you do in
Ma'am,
this?
electron microscopy can be considered, ma'am.
Why do you want to do electron microscopy?
The best
The presence
Oxford
of the
classification.
electron dense deposits.
Electron dense deposit, you're already seeing immunofluorescence, which is showing
Yes,
you
ma'am.
deposits.
Yes,
You
ma'am.
don't need an EM to look for deposits. See, electron microscopy, if you will do electron microscopy in each and every biopsy, you will delay the diagnosis, right?
Yes,
But
ma'am.
first you will have to release a biopsy report with immunofluorescence
Oxford
and
class.
light microscopy. What else will you add in your report?
Best Oxford classification. Best to see. Oxford classification for IgA
Very good.
nephropathy.
Who's saying that?
Ruby.
Ruby, very good. So Ruby, you're absolutely right. You will add, yes, Sarika is also saying you will add the Oxford classification. What is the Oxford classification? It looks at five parameters.
Hypercellular. Best to see.
Granular.
Hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis, tubular atrophy, and crescent. So we'll
Very
give a
good.
score 0, 1, and 2 based on what the criteria is.
So in this biopsy, Sarika, what is your score? For M, what will you say? M?
1.
M1. Yes, most of the glomeruli are showing you mesangial hypercellularity. E?
E1, ma'am. Endocapillary.
E1, because I showed you endocapillary hypercellularity. S?
S1, ma'am.
1.
Segmental sclerosis.
Very good, because you had segmental sclerosis. This is seen. So there is endocapillary
E1.
hypercellularity. Very good. Then C? 0, because you don't see a very good crescent. So C1 and C2 dependent on the number of crescents that you see. C1 is 25%. If more than 25%, then you say C2. But if you don't find crescents, it's C0. For tubular atrophy, how do you do it? T1 and T2?
T1, 26 to 50% tubules. If there is a tubular atrophy, will give T1, and T2 is more than 50% tubular atrophy.
Very good. So this will be, if we look at the tubules, there will be T1. Of course, you're not seeing the whole biopsy in this, but it was T1. Okay, and you have IgA deposits. Of course, if you do an electron microscopy, you will find mesangial deposits, right? These will be the mesangial electron dense deposits that you see. Okay. So this was a IgA nephropathy. So apart from IgA nephropathy, as I said, this is just a pattern of disease, mesangial-proliferative glomerulonephritis. If you find IgA, you will say IgA nephropathy. In this patient, there was rash also. So you can say IgA vasculitis. But generally, those patients also have crescents also. Generally, HSP or vasculitis has crescents also. But fine, it is IgA vasculitis. But if you have a mesangial-proliferative pattern of injury, you also need to consider other diagnosis and make your definite diagnosis on the features that you are seeing. So for example, in this case, if it would have been a full house staining for IgG, IgM, IgA, C3, C1q, kappa, and lambda, I would have said, then I would have started thinking of lupus nephritis. Right. So lupus nephritis class 2 can also have a similar pathology. Always remember that. So it is when you integrate all the findings that you make a definite diagnosis. If you have a cryoglobulinemic, you may have IgA and IgM, but then you start seeing hyaline deposits and you have intraluminal thrombi, which are cryoglobulin positive. So intracapillary cryoplugs are seen, which are PS positive, and of course EM will help you. Similarly, if you have a resolving PIGM, that is post-infectious glomerulonephritis, you may just see mesangial proliferation. But in that case, you will have IgG and C3. most likely you will not have IgA. Sometimes you may also have an IgA dominant PIGN, but that will also show you more endocapillary hypercellularity, and at times you will require to look at electron microscopy to make a definite diagnosis. And of course, a history of the patient. So what I'm trying to emphasize is always look at a biopsy with an open mind. Look at the pattern that you see in the glomeruli, and based on your immunofluorescence, then you make a diagnosis or a differential diagnosis. Okay, is it clear?
Yes.
Okay. Any other comment? Dr. Sandeep, do you have any comments for this case? Because IgA, I think, is one of the commonest glomerulonephritis that we see.
So I would just like to highlight that how the pathological diagnosis and the pathological advancements has actually changed the whole perspective and treatment of the disease. So
Right.
what seems so basic and all of you seem to be aware of was an Oxford classification and the MES scoring, which surprisingly just started not even a decade back, almost a decade and a half back. So prior to that, it was just a diagnosis of IgA nephropathy, and it was left onto the clinician to treat whichever way. Now we have a more structured reporting world over, and that has dramatically changed the way we look at the disease of IgA nephropathy and treat it. So that's what I meant by saying initially that it's an ever-evolving field. First, now correlating beautifully between the clinical and the pathological fields to arrive at a diagnosis as well as treatment. So IgA nephropathy maybe best represents this case.
Thank you. Thank you, Dr. Sandeep. I think that was a very good comment. And that is how what we need to emphasize to the students, that try to look at it as a holistic picture, and what you need to report as a pathologist, that is very, very important. Okay, now let us look at case history number 4. Ruby, are you there?
Yes, ma'am.
Would you like to cover this?
Yes, ma'am.
Yeah.
12-year-old boy, clinical presentation, facial puffiness, decreased urine output for 5 to 6 days, and cola-colored urine. So on physical examination, pulse rate was 74 per minute, BP was 126 on 90, and respiratory rate was 14 per minute. There was pallor and edema present. So this can be a nephritic syndrome. And for cola-colored urine, facial puffiness, so we will think more in terms of glomerular nephritis,
Okay.
post-infectious glomerular nephritis.
Okay, agreed, Ruby. Agreed. Did you attend the last time that I had a lecture on urine microscopy? Who was there last week when I had I took a lecture on urine microscopy? I showed you some casts. What are the casts that you see in the urine? I'm just trying to see how many of you were there. What are the typical casts that you see in these patients?
Cam phosphor.
That is a hyaline cast.
Cast.
Okay. Okay, we'll talk about it again. Okay, so there was no history of joint pain, chills, rigor, fever, or sore throat. So renal biopsy was performed. What do you find in the renal biopsy? So the first thing that you look at the renal biopsy, tell the number of glomeruli. So there were 13 glomeruli. Let me straight away take you to the high part. So what do you see? How do you describe? What is the left side picture?
It's any staining of cortex of cortical biopsy, showing 2 glomeruli with increased endocapillary hypercellularity, mesangial hypercellularity, and mild mesangial matrix expansion. Mainly, there is segmental cells, mostly neutrophils can be seen in endocapillary and mesangial hypercellularity. And the investigation is also showing these neutrophils, scattered neutrophils, and few mononuclear cells are also seen. Then tubules are showing mild simplification and vacuolation. In the left side here, fasting, so we can see vacuolations and simplification of the tubules in this. And also the same 3 glomeruli can be seen with showing mesangial matrix expansion and mesangial hypercellularity and endocapillary hypercellularity with neutrophils and mononuclear cells, mostly neutrophils.
Very good. So first of all, if you look at this biopsy, this is HE stain. This is a parodic. The only thing I can add is that you should always say it is a global lesion. You agree? Both of the
Yes.
glomuli, if we see the biopsy here also, it was a diffuse lesion. All of the glomuli are involved. So it is a diffuse lesion. Then it is a global lesion. Second thing. Third is that there is enlargement of the glomuli, which is very, very evident. And of course, you have endocapillary hypercellularity with neutrophils. One thing I would like to point out on, always remember that the inflammatory cells are better seen on an HE stain than they are seen on a PA stain.
Yes.
So that is why we always do an HE stain. If you look at these, it will be always be easier for you to identify these neutrophils in the interstitium and in the glomerulus. Then it is so full of neutrophils that you are easily able to see them. But sometimes when they are only few, it is always easier to see them on an HE stain. So that is one point which you always need to remember. So I agree with whatever you have said, Ruby. Now we move on to the legs. So this is to show you in the high part. This is what stain?
HNE.
HND. I think you can better see whatever you have talked about, that you have these neutrophils. Endocapillary hypercellularity, because there is complete obliteration of the capillary loops. And of course, all the other findings are the same. And this is the PS in high power. Okay, so there were a lot of neutrophils. When you see this type of a pattern where you have endocapillary hypercellularity with a lot of neutrophils, this is known as typically an exudative pattern of proliferative glomerulonephritis, right? Okay, so this is in all the 4 stains that you see this glomeruli. This is in silver methenamine and MT. Okay, so what is your differential? So when you see a proliferative pattern which is diffuse, so when we say it is a proliferative glomerulonephritis when we have endocapillary hypercellularity. So when you have a diffuse proliferative glomerulonephritis pattern, what are the differential diagnoses? So this is a list of the differential diagnoses that you should always keep in mind. One, as you said, is post-infectious glomerulonephritis. Second, C3 glomerulopathy.
And glomerulonephritis.
Right, but you in MPGN, what else will you find? MPGN will also show you.
Dense deposits.
No, it will show you
Cramp
membranous
track appearance.
cramp track appearance with double contours. So if you have a diffuse proliferative pattern with a double contours, it becomes MPGN pattern. Then IgA nephropathy can also show you. I showed you endocapillary hypercellularity. So IgA can show you endocapillary hypercellularity, which can again be diffuse sometimes. And then you can have PGN-MID with monoclonal proliferative glomerulonephritis with monoclonal immune deposits, lupus nephritis, cryoglobulinic, and monoclonal immunoglobulin deposition disease. So on light microscopy, when you looked at light microscopy, HE and your PS stain, these are the differential diagnoses which should come to your mind. After this, then you will do the immunofluorescence, and accordingly you will make a definite diagnosis. Okay, in this, the IgG was positive and C3 was also positive, but the IgG is typically seen as, how will you describe, Ruby?
Postgranular capillary wall deposits.
Very good. So you have to say what is the pattern and also the intensity. So the intensity can be scored on a scale of 0 to 3 plus or 4 plus. It depends upon what are the other, but in this, the image is not so bright, but it was 2 to 3 plus positive deposits of IgG. And you have also C3 deposits, which are not brighter than IgG. When you look at these two stains, IgG and C3, always remember to compare these two, which is brighter, whether IgG is bright or C3 is bright. It helps you make a definite diagnosis of C3 glomerulopathy versus post-infectious glomerulonephritis, but in the later stages, C3 can also be a little more brighter. Okay. So this was the EM on this case. Find in post-infectious glomerulonephritis on electron microscopy.
Thumb-shaped electron dense deposits.
Very good. So that is what I have highlighted with these stars, the yellow stars that you see. These are the hump-like deposits. Okay. Subepithelial hump-like lumpy bumpy deposits. This is a hump-like deposit which is sitting on the capillary basement membrane. You do not always require an electron microscopy, but it helps you sometimes when you are in a mix in making a diagnosis. So for example, in this case, because there were C3 deposits and also IgG deposits, so you will be thinking whether it is a typical PIGN or not. So it sometimes helps. Okay, because both kappa and lambda was positive, you will not think of PGN-MID, that is proliferative glomerulonephritis with monoclonal immunoglobulin deposits, because that will show only one type of light chains. Okay, so this was a case of proliferative and exudative glomerulonephritis. I just wanted to point out that those who are interested in renal pathology can go through this paper, which is a nice paper which talks about consensus definitions for glomerular lesions by both light and electron microscopy. It is a nice paper. And what does it say about endocapillary hypercellularity? It defines it as increased number of cells within the capillary lumen which cause luminal narrowing or occlusion. And what is exudative? When you have endocapillary hypercellularity with large number of neutrophils. So in this case that I showed you, this was a patient with proliferative and exudative glomerulonephritis. Okay, in this patient, the ASO titers were raised, and on follow-up, the serum creatinine fell. There was a decrease in the serum creatinine with time, and the serum C3 levels were increased. So at the time of presentation, they were low, but they increased. So that is important in PIG. So this was a case of diffuse proliferative and exudative glomerulonephritis, query post-infectious glomerulonephritis. So because of the typical history, of course, you will give a possibility of PIG. And this is just to tell you that there could be an acute PIGN type picture, which we are seeing, which has prominent glomerular neutrophils. It may be subacute, where the neutrophils decrease, but there is endocapillary hypercellularity, or it could be resolving PIGN, which may show just mesangial hypercellularity. As I showed you, mesangial hypercellularity can be seen in resolving PIGN. So always remember to take the proper history and look at the larger picture and your immunofluorescence before suspecting what can be the pathogenesis involved. So this is again a case of IRGN, that is infection-related glomerulonephritis. So this is exudative because it has more than neutrophils which form more than 50% of the hypercellularity. As I said, subacute will have mesangial proliferative or sometimes an MPGN pattern. And one condition which can also show a typical proliferative glomerulonephritis is IgA dominant PIGN, which is typically seen in Staphylococcus aureus infections. Okay, this is just a flow chart to show you how immunofluorescence helps you in making a differential diagnosis. And of course, transmission electron microscopy comes in to make a definite diagnosis, especially when you're looking at organized deposits. Okay. So Dr. Sandeep, do you have any comments or do we have any questions on the last case?
Nothing much. Yeah, historically, almost looked like a post-infective glomerulonephritis. Normally, we would not do a biopsy for such a case unless they have an atypical presentation, poorly healing, persistently low C3 levels. So that would be one area where we would be doing a biopsy. And obviously, there are so many close differentials which can present the same way. So it's quite relevant in certain cases to do a biopsy.
Yeah, that is what I showed. This patient presented with low C3, and with follow-up, though it increased, the patient had low C3, and therefore maybe at that point of time also a possibility of C3 would have been thought of, though the clinical history was quite suggestive. And now we know that C3 glomerulopathy can also present with a sore throat. The infection can precede a C3 glomerulopathy. So that is why maybe a biopsy was done. But yes, these are the cases which generally the typical cola-colored urine biopsies are not done completely. So students, any question on that? Otherwise, we move on to case history 5. Okay, Swasti, are you there? Would you like to take up this case? We'll finish it in 5 minutes. Swasti, are you there? So can we go back to Mampi now? Mampi, can you take up this case? It is a related case that you just saw.
Yes, ma'am.
Yeah.
15-year-old boy presented with pedal edema, 2 months. On investigation, urine protein 3 plus, 24-hour proteinuria 2.4 gram, urine microscopy, WBC 5 to 6 high power field, RBC 5 to 6 high power field, serum creatinine 1.8. So we can see there is pedal edema, and protein is it is not severe proteinuria. It is 2.4 gram. Urine microscopy shows there is hematuria more than 5 per high power field. WBCs are
So
also
what is
there.
your clinical syndrome? What is your renal syndrome in this?
It is
Nephrotic.
Nephritic. It is nephritic syndrome. Isn't it? Yeah. Okay. Now let us look at the biopsy. What do you find in the biopsy, Mumpy?
It's loading. Okay. It is a PA stain. So
Very
in the
good.
stain, we can see there is one glomeruli, which is
Glomerulus.
showing.
When you talk of one glomerulus, it is glomerulus. When there are more than one, then it is glomeruli. Okay?
There is
Okay. So this is glomerulus.
one glomerulus, which is showing mesangial cell and matrix expansion is there, and there
One
is
is
obliteration
mesangial.
of
Bone.
mesangial cell proliferation and matrix expansion is there. Few capillary lumens are obliterated, so there is segmental presentation, and tubal atrophy is also there.
Yeah, so for if you look at this glomerulus, let's just talk about the glomerulus first. So the glomerulus is showing you some lobular accentuation. You can see these lobules. All of the, I see most of the capillaries are all obliterated, right? Do you see any patent capillaries anywhere? Except for one or two here and there. Most of the capillaries are completely obliterated and occluded. So there is global. Do you think there is endocapillary hypercellularity?
Yes.
Do you see capillary loops here? Patent? No, you don't see any capillary. This is the Bowman space, right? Right.
Yeah.
Do you see any capillary loops here? No. Right. You should have seen capillary loops at the periphery. Always look at the periphery. So if you don't see capillary loops at the periphery, this is endocapillary hypercellularity. Most of the endocapillary hypercellularity will always be accompanied by mesangial hypercellularity. Okay. So there is global endocapillary hypercellularity with lobular accentuation. You look at these lobules, which are very prominent, right? Of course, there is tubular atrophy. So these are the findings. What is this stain?
And there is inflammatory cell infiltrates also. This is okay. Yes. This is a silver stain. So
what do you see?
Double contour.
It's very good. So you just look at the periphery. Always when you're looking for double contours, look at the periphery. If you look at the periphery of this is a lobule. You can see this double contours. These are two basement membranes which are running together. Similarly here, you see the double basement membrane. Okay. So this is also double. So everywhere you're seeing duplicate. This is double contouring of the glomerular basement membrane. See, for the last case I show you, diffuse proliferative may show you some segmental double contours. But if you see global double contouring, then this is a case of, what is this pattern? This will be known as cramp track is fine, but what will be the pattern when you talk of in diseases, glomerular diseases? What will be this pattern? This is a cramp track is a finding.
Global.
MPGN pattern.
Very good. The pattern is MPGN, that is membranoproliferative glomerulonephritis pattern of disease. So now you've made a diagnosis of MPGN pattern of disease. Now you move on towards your immunofluorescence and try to look for the pathogenesis. Okay, so this is again to show you the MPGN pattern. This patient, this biopsy also, what is this? Ruby, what do you see in this? What is this?
One question, ma'am. Segmental questions.
Very good. So this is a crescent. So I told you what is a crescent, which is something which is a proliferation of the parietal epithelial cells along with infiltration of inflammatory cells. It is in the Bowman's space. right? So this is a cellular crescent because more than 75% is formed of cells. And it obliterates the Bowman's space, also known as the uterus. And this is a glomerular tuft, which is again showing you similar findings that we were seeing there. Okay, so this is a glomerulus showing you crescent. Very good. So this is the same glomerulus which you are looking in the silver methenamine stain, where you look at the crescent, which will not be silver methenamine positive, whereas the capillary loops, you can beautifully see the double contours. Agreed? This is the MPGN pattern of injury with crescents. This is the immunofluorescence. Now, can you read up the immunofluorescence? What is your finding?
It is IgG negative and IgA positive.
IgA was 1+. What is this?
1+. Oh, sorry, C3 granular positive.
How will you describe the C3? Granular, mesangial, and capillary wall deposit.
Essential and capillary positive.
So what is your diagnosis now? MPGN pattern of injury with C3 dominant deposits.
C3 dominant.
So what is your diagnosis? C3?
C3, no.
Sarika is telling you.
C3 glomerular.
Very good. So MPGN pattern of C3 can also have, I showed you DPGN pattern. It can have mesangial pattern. But MPGN pattern of injury with C3 dominant deposits, you say C3 glomerulopathy would be your diagnosis in this case. So I will say this is a membranoproliferative pattern of injury with C3 glomerulopathy, which also has something like crescents, right? Okay. So now the question is, what else can be done to refine your diagnosis? You have made a diagnosis C3 dominant. What else can be done to refine your diagnosis? Anybody?
Electron microscopy.
Very good. Electron microscopy. Now electron microscopy comes in. How will electron microscopy help you?
There will be subendothelial deposits.
Right. But why do you want to do electron microscopy? In any case, if you are thinking of, if you think that there will be subendothelial deposits, you may not do electron microscopy. Why do you want to do an electron microscopy? Apart from subendothelial deposit, what are the other types of deposits that can be seen? Let me refine the question. So you can have subendothelial deposits and
Subepithelial.
no, not subepithelial. Any other type of deposits?
Between the because of the double contouring, we can see the double contouring.
The double contouring, the subendothelial deposits can also cause double contouring, right? Because of the new basement membrane formation. But there are other type of deposits in which can. So C3 glomerulopathy is not a single disease. It can be very good. Sarika is telling you it is ribbon-like dense deposits. So C3 glomerulopathy can be divided into two types. So MPGN pattern can have immunoglobulin positive or immunoglobulin negative. When we are talking of immunoglobulin negative, like in this case, which is C3 dominant, it could be C3 glomerulonephritis, in which you have subendothelial deposits on electron microscopy, or it may have dense deposit disease, where you have these ribbon-like deposits within the membrane of the. So that is how the EM will help you. So you have reached to this point, C3 glomerulopathy. Now to further reach to this point, you will require electron microscopy. What my point? MPGN pattern can be also seen in a typical immunoglobulin positive injury. It is not necessary that always C3 glomerulopathy will be there. So with a similar findings, if I would have showed you an IgG which was 3+ and C3 which was 1+, it would have become immunoglobulin positive MPGN. But now I am showing you which is C3 dominant, then it becomes C3. So everything changes according to immunofluorescence, right? So your pattern is MPGN, immunofluorescence. If it is C3 dominant, it becomes C3 glomerulopathy. If it is immunoglobulin positive, IgG positive, it becomes immunoglobulin positive MPGN. Then once you've made a diagnosis of C3 glomerulopathy, you do a EM. You look at whether there are subendothelial deposits or they are dense deposits. Okay. So the other thing which you need to remember is that apart from this MPGN pattern, Typical MPGN pattern can also be seen in a large number of conditions. They can be positive IF or negative IF. As I showed you in other conditions, you should always make your diagnosis according to your immunofluorescence patterns. So different diseases will have different immunofluorescence pattern, but the morphology can be similar. Okay. So I'm not showing you a case of crescentic glomerulonephritis, but because I showed you crescent, I will like to let you know that once you see more than 50% of glomuli involved by crescents, you can label it as crescentic glomerulonephritis. And on the basis of immunofluorescence, you will further make a diagnosis of anti-GBM disease, immune complex associated crescentic glomerulonephritis, or post-immune ANCA-associated crescentic glomerulonephritis based on your immunofluorescence. So immunofluorescence, if it is linear deposits of IgG, it is anti-GBM. If there are no deposits, it is post-immune ANCA-associated. And if you have granular deposits, immune complex deposits, then you think of immune complex mediated crescentic glomerulonephritis. This is just a list of people who are more interested in glomerular pathology. How do we make out whether it is anti-GBM post-immune versus immune complex? Okay, and this is a typical histological classification of ANCA-associated, where you try to find out what are the typical type of crescents, what are the percentage of glomuli which are involved by crescents, and what are the number of globally sclerosed glomuli. Okay, so this is just to show you that many of these conditions which I was showing you can present with crescentic glomerulonephritis. This is an infection related which has crescents, IgA with crescents, lupus can have crescents. Of course, the MPGN that I just showed you and enoxazoline purpura, it generally presents with a lot of crescents. Okay, so all of these immune complex mediated GNs can be crescentic. Of course, the immunofluorescence and the other features will help you reach a definite diagnosis. Okay. Going on to the last case. Then we have Sarika now. Sarika?
Yes, ma'am.
Dr. Sandeep, can you please make your comments on the last case? Sorry to.
Okay, so just to give you interesting trivia, the whole concept of C3GN or MPGN has actually been revolutionized by Dr. Sanjeev Sethi. So he's currently in Mayo, but he's from India, and he did good his MBBS and initial part of medical training from India only. And he's the one who has completely changed the outlook of a disease which was ever ambiguous as MPGN. And now the way the classification, as Dr. Vinita showed, is practically what we call as Dr. Sethi's classification of MPGN. So it's quite interesting how things have evolved here.
Yeah, I think Dr. Sethi has done a lot of contributions to renal pathology. One is MPGN and the second is membranous. So I think that is, as an Indian, we are really happy that we have somebody who was there, studied in India, and now has reached to those heights and made these differentials. Thank you so much, Dr. Sandeep, for pointing that out. So the last case, Sarika, would you like to take up?
Yes, ma'am. 56-year lady presented with pedal edema and a nephrotic proteinuria. Adult female plus nephrotic. I have to first think of membranous nephropathy.
Very good, very good.
And then if she is diabetic nephropathy also.
Okay, good.
And amyloidosis. Last possibility, amyloidosis.
Okay, so these are the most likely diagnoses that are coming to. So what is your, this is the histology of the biopsy. So what do you see? What is the stain?
PAS, ma'am.
What is your finding?
Glomeruli with global capillary wall thickening with no significant hypercellularity and no endothelial proliferation, no crescent, and tubules shows mild tubular atrophy or early tubular atrophy.
But do you think this glomerulus is normal? What is the finding in the glomerulus?
Increased.
What is the increase?
Increased mesangial proliferation.
Okay, very good. So there is no mesangial proliferation because only maybe there is some here and there where you see 3 cells, but you have just 3 cells, not 4 cells. That is fine. But what is more important is to see that there is increase in the mesangial matrix.
Mesangial matrix. Yes, ma'am.
Okay. So in the PA stain, you see that there is increase in the mesangial. There is mesangial matrix expansion. The second thing you need to, whenever you see this mesangial matrix expansion, always look at what is the tintorial quality of this expansion. Compare it with the color of the basement membrane. Always compare with basement membrane. Do you think it is the same color? Is it lighter or is it darker?
Lighter than the color of
the basement
membrane.
membrane. So
Basement
it appears that there is, so the normal, if the mesangial, just the mesangium would have been expanded, it would have been the same color as the basement membrane, right? Because the normal, the mesangium is PS positive. But here you are seeing lightly PS positive. So that comes to your mind that some material is getting deposited. Always remember that. Okay.
Yes, ma'am.
Now we come to silver methanolamine. What do you think? You see the same material. It has a light green color. Whereas it would have been just mesangial matrix. It would have been, what would have been the color? Black. Because it is greenish. So because we are using light green as a secondary stain. So it is a little greenish. So that means there is something which is getting deposited. So at this point of time, the first thing comes to your mind is a deposition disease. Everybody agrees?
Yes.
Yes, ma'am.
So what next will you do?
Congruent. Congruent
Very
for
good.
amyloid
The first thing you
deposition.
will do is congruent. But however, in this, the congruent was negative and these deposits were not congophilic. However, they were positive for IgG, kappa and lambda. So what are the other conditions in which you have deposition?
Polyclonal IgG deposition.
It's a polyclonal. But what is the disease known as? Condition known as? Of course, it is polyclonal IgG deposition. But what will be the disease? What are the other conditions in which you can think of depositions? This type of deposition. Apart from amyloid. If it would have been congruent positive, you could have thought of amyloid, but it is not congruent. What else will you do? What will you think of? What is your differential? Anybody?
Light chain deposition disease.
Not light chain deposition. Why? Because kappa lambda both are positive.
Dense deposition
Dense
disease.
deposition.
Dense deposition disease. What is this dense deposition disease? There is no condition known as dense. Dense deposit disease, I already showed you.
Ribbon-like deposits.
Ribbon-like deposits. Very good. So it is not ribbon-like deposits. This is something which is secondarily deposited. Right? So what are the other deposition diseases? Okay, let me show you. So this is to show you amyloidosis typically. So what will amyloid show you? I showed you this case in the first instance, right? This is lightly PS positive material which will be negative on silver staining and it will be congophilic, right? When
Yes,
you do a, when we do a apple polarized under polarized light, it will show you a typical apple
green birefringence.
So this is amyloidosis, typical amyloidosis. But there are a large number of conditions which can present like deposits. Apart from these, one is immunotactoid, diabetes. What will happen in diabetes? It will also show you this type of a deposit, but it will be black on
positive and
it will be PS positive. It will be more PS positive. As I told you, when there is matrix deposition, it is PS positive. So in diabetes, what happens is mesangial matrix is increased. So that is why it is beautifully PS positive in black on silver stain. So you can have fibronectin, you can have collagen, and one more which is not in the list is fibrillary glomerulopathy. Okay, so always remember that there are a large number of conditions which can have a deposition diseases, and according to whether they are congruent, the first stain that you do is congruent, as you rightly said. If it is positive, you think of amyloid and try to find out what is the type of amyloid. If it is negative or congruent, you look at kappa and lambda. If it is polytypic, these are the conditions. So for in our case, what do you think? It is polytypic or monotypic?
Polytypic.
Polytypic. Why
Polytypic.
Polytypic? Because both kappa and lambda
Both
are
kappa
positive.
and lambda are positive.
These are the conditions which can show you this type of a deposit. Fibrillary will be the first, immunotactoid, cryo, and other conditions. Okay, so
Yes.
so this is to, and I always want to tell you that once you have made a diagnosis of amyloid, you always need to identify the protein and of course consider all of these conditions. There are a large number of conditions which can present you as a deposition disease, like MIDD, PGN-MID, fibrillary, immunotactoid, fibronectin, and so on and so forth. So ideal will be to do an EM and to look at it because these are organized deposits, but there is another immunohistochemistry. If you do not have EM, or apart from EM also, you can do an immunohistochemical stain, that is DNA JB9, which is typically seen in fibrillary glomerulonephritis. So that is what we did, and it was DNA JB9 positive. And this is a typical electron microscopy of this case, that we found a large number of fibrils. In amyloid also we find fibrils, but in amyloid the fibrils are very thin as compared to fibrillary glomerulonephritis. And why are these known as organized deposition diseases? Because on electron microscopy these deposits are organized into fibrils or tubules or crystalline structures and so on. So that is how these are known as organized deposition diseases. So in this case, the diagnosis was fibrillary. This is another case of amyloid to show you that there can be a large number of capillary wall and blood vessel deposits. Okay, so whenever you have renal amyloid, always try to make what is a type of amyloid. That is, AL amyloid will have kappa or lambda positivity, mostly lambda. AA will have immunohistochemistry for AA can be done. And of course, you can do mass spectrometry for defining the different types of amyloid. You have more than 25 amyloids which can be seen. So these are the different type of amyloids that we see. This is amyloid A, amyloid AFib. This was a case of leukocyte LAC2 amyloid that can be seen, which typically presents with interstitial amyloid deposits. Okay. So always remember that once you have made a diagnosis of renal amyloidosis, always try to type it. So these are the other conditions which I was talking about, the fibrils, microtubules. So fibrils are seen in fibrillary, immunotactoid shows you typical tubular arrangement, and depending upon the diameter and the organization, you can make a definite diagnosis. There are other conditions which can also show a typical deposition-like appearance, but these are non-organized deposits like in MIDD. Okay. The other condition like fibronectin glomerulopathy will also show you a similar appearance, but of course it is positive for immunofluorescence by fibronectin, and you can also use a immunohistochemical stain. Similarly, collagenofibrotic, you can do a immunohistochemical stain, and EM will show you typical collagen deposits on the below the glomerular basement. Okay. I just wanted to make a one point about lupus nephritis. Lupus nephritis is one disease which encompasses almost all the pathologies that you see on a renal biopsy. So it can be a minimal change disease. It can be a mesangial-proliferative type of a disease. It can be a focal proliferative disease. It can be a diffuse proliferative disease. It can be a membranous disease. It can also show you organized deposits. So this is one condition which can show you the whole spectrum of the renal biopsy diagnosis that you see. And of course, when you have a patient of lupus nephritis, you also need to do the NIH lupus nephritis activity and chronicity scoring. This is just in 2 minutes. I'll tell you that whenever you have a kidney biopsy report, you always mention the gross, LM, IF, and if you have EM finding. What is your primary diagnosis? What is your secondary and the comment? I'll show you an example. So for example, the disease entity will be IgA. Pattern, whether it is presenting as MPGN, mesangial-proliferative. For example, C3 glomerulopathy can be an MPGN pattern. It can also be a mesangial-proliferative pattern. And then you give the scores or the grades. For example, the lupus, you will give the NIH score. You will have the Oxford or the MES scoring for IgA. And you mentioned the additional features like glomerulosclerosis, degree of interstitial fibrosis, and tubular nephropathy. As I said in the first part of my lecture, you may have a primary, but always remember there may be other conditions in the same. It may be a multifactorial etiology. So you may always, sometimes we find IgA with granulomatous interstitial nephritis. That will be your secondary diagnosis. So this is how the kidney biopsy report should look like. So this is an IgA nephropathy report. We say IgA nephropathy. What is a pattern of injury? Is it diffuse mesangial, focal endocapillary, or focal segmental? What is a score? What are the additional features like whether there is focal global glomerulosclerosis, where moderate tubular atrophy, interstitial fibrosis, and sometimes you may have IgA nephropathy in a patient of diabetic nephropathy. So you will say the secondary diagnosis that patient also has class 2 diabetic nephropathy. So that is how, as a renal nepropathologist, you need to look at all the 4 compartments and always remember that there may be multifactorial things that are going on in the renal biopsy. So this is the summary of my presentation. I will say that the renal biopsy should be properly handled. Never touch it with a forceps. Always touch it only with a brush. Always do a clinical correlation, appropriate investigation and serology. IF has to be done in each and every biopsy, each and every. I cannot say that more definitely that without an IF, you should not report a renal biopsy. You can do an immunohistochemistry or a paraffin IF if you do not have tissue for IF. And of course, TM may be essential in some conditions like Alport's and the thin basement membrane and others, organized deposition disease, but it most of the times is complementary to LM and IF. And there are a lot of new markers, scoring system, and classifications which are now available, which you have to take into account. And of course, the renal biopsy should be structured. So with this, this is all from me, and thank you so much for your listening. I will be very happy to answer any questions, and I will ask Dr. Sandeep to give his comments on the if you have.
So thank you, Dr. Vinita. It has been a very interesting session. I believe the students would have benefited a lot as to how to go around reporting a kidney biopsy. As you would have realized that it's a complicated process. You have to see the 4 compartments, report all the 4 compartments, do multiple staining, and then on to top of all, you have to correlate it with the clinical correlation. And new scoring systems, new stains, like in February, the JB9 stain has just come up. It was not there. It's a rare disease. Hardly any literature was available. And then suddenly, other than EM, now we have a simple diagnosis that you do this stain and you can get that. Similarly, there has been some from Dr. Sethi unit, there has been some protocol of doing ApoE staining in patients with dent deposit disease as compared to C3G. So, which makes then EM, which is not that easily accessible to most of us, you can do away with EM and look at these alternative stains and come to a diagnosis without an EM. So it's a very, very well taken class, Dr. Vinita. Thank you so much.
Thank you, Dr. Sandeep, for being there. Thank you so much. Your comments were really, really helpful. I think the students would have gained a lot. And I would also like to say that most of the students take back that EM is so very necessary for a renal biopsy interpretation. Please don't think so. EM is not the answer for all of your diagnosis. EM helps in certain cases, but does not give you an answer in all of your cases. So look at your light microscopy, look at your immunofluorescence, do the special stains, the new immunohistochemical markers which are now available to make your diagnosis, and don't think that because you do not have an EM, you will not be able to make a good diagnosis. Never think about that. Of course, EM helps, but EM is not the answer to all questions. Thank you so much. Thank you for your patient hand, and I will be really happy to have any questions. Dr. Sheetal and Dr. Pooja, do we see any questions in the chat box?
No, ma'am, lot of appreciation. Everybody is thanking you. And I would like to say it is such a vast topic, and you very lucidly covered